Good afternoon, everybody. It's my great pleasure to introduce you to our speaker this afternoon, somebody who I consider to be a Liverpool success, Dr. Michael Makanga. Michael trained in medicine in Makanga in Uganda, and then he had the great vision to decide the next phase of his career would be in Liverpool. So in the mid-90s, he made his way over here and unfortunately ran into me, where he did a master's and then a PhD in laboratory-based science, where he was very successful, was one of the first people to look at molecular the molecular understanding of mechanisms of drug action. First person to do proteomic studies on drugs and parasites. Following on from that, Michael moved to Kalifi, to the Wellcome Trust unit there, where he ran the clinical trials unit. And then after that, he moved to Cape Town, where he worked for EDCTP as the regional director. He was there for 10 plus years through its evolution, and in 2016 moved to The Hague as the executive director of EDCTP. So Michael is going to tell us about the evolution of EDCTP and what it means for LSTM. And I won't read out his title, it's there for you. Over to Michael.
Thank you very much, Steve. Good afternoon, ladies and gentlemen. I'm really delighted to be back to Liverpool and to speak to you about the role of the European and developing countries clinical trials partnership in research and development for poverty-related diseases. And I'll have a forward-looking perspective because I also want to give you a bit of insights on where we are going. Starting a bit with an overview of the program, EDCTP is a public-public partnership, meaning that this is a partnership that involves institutions that are mandated by the governments in Europe and Africa and co-funded by the European Union. And the program has been running for the last 16 years, but for the next few minutes I'm going to focus on the work that we've been doing under the second program, which started in November 2014. And this is a program I've been leading. Starting with a strategic approach, our program is aiming at making a contribution towards the reduction of the social and economic burden of poverty-related diseases in sub-Saharan Africa by enhancing the research capacity and accelerating the development of both new and improved medical interventions against poverty-related diseases through all phases of clinical development, with a particular emphasis on phase 2 and 3 clinical trials. We have 5 program objectives, but for the purpose of this meeting, I'll mainly focus on the first 2, and that is increasing new or improved medical interventions and increasing cooperation with sub-Saharan Africa through capacity development for clinical trials, ethics, and regulatory activities. Our model of implementing this work is integrated in that the core of our activity is clinical research, and this covers all phases of clinical trials, including product-focused implementation research. And this is the core activity, and 88% of our budget goes towards research and development. Secondly, we have development of capacity for individuals that can do and perform high-quality clinical trials. So we have a very comprehensive fellowship scheme, starting with preparatory fellowships, targeting the first 2 years, post for clinicians in the first 2 years following the exposure to clinical research, and postdocs, first 2 years postdoc. And then we have the collaborative mentorship fellowships. These give people an opportunity to get attached to product development initiatives and also to work with the pharmaceutical companies to get the rare regulatory type of skills to conduct high quality regulatory trials. And they go back to implement these in the low and middle income countries. And then we have the career development fellowships, which now target the first 5 years postdoctoral, or the first 5 years for the clinicians that are involved in clinical research. And this is to really help them become independent researchers and to start establishing research teams. And then we have the senior fellowships, which are for the mid-career and senior researchers that are mentoring others that have to have PhD programs and master's trainees as part of their research. And these really, there is no cap. It's those that have more than 5 years postdoctoral experience and are able to do this kind of work. As of this year, we've also introduced the Senior Fellowship Plus, which is a tandem scheme pairing up established researchers that can work with researchers from high endemic countries that may have limited expertise in research. And then on the side of capacity development and countries and health systems and institutions, we have the Regional Networks of Excellence, which is funding that is providing for institutions that are networked at regional level to develop capacity for clinical trials, and these have been developed in 4 regions in Africa. And then other areas where we support strengthening of the product-focused health systems research, strengthening of ethics and regulatory environment, and translation research. And in terms of disease coverage, we cover TB, HIV, malaria, neglected infectious diseases, those that are on the priority list of WHO, emerging and re-emerging infections of particular relevance to sub-Saharan Africa. This is where we have Ebola, yellow fever, Lassa fever, the hemorrhagic fevers. Lower respiratory tract infections, this is really targeting the under 5s, especially where there is high mortality. And the same applies to the diarrheal diseases. You realize that we have a broad coverage in terms of disease. But in that, we also have focus in diversity, where we have pay special attention to vulnerable populations. Maternal and child health, where we cover pregnant women and newborns, children and adolescents, people living with co-infections and comorbidities, and paying special attention to the genetic diversity, especially in Africa. The clinical studies that we support cover, we focus on the clinical development from phase 1 to 4, plus product-focused implementation research. But 54% of our studies or clinical trials are in phase 2 and phase 3 clinical trials. Where are we in terms of program investments? Starting with, I'm focusing on the last 4 years. We have a total investment of 552 million euros in 247 projects that are awarded to date. We still have more that are coming on. And 88% of our budget goes towards research and development. We spend a sizable amount to support enabling environment for research, other than fellowships. And then we have the fellowship schemes. As of now, we have 109 fellows that are networked in an alumni platform. Much of our work is happening in sub-Saharan Africa, so 62% of our budget is spent in sub-Saharan Africa. And we have now a broad network of 226 institutions in Africa that we're working with, and 139 institutions in Europe. In terms of where the funding is going, as you can see that majority of the funding is going towards the main 3, TB, malaria, HIV, and then we have neglected infectious diseases, emerging diseases, diarrheal disease, and lower respiratory tract infections. As you know, the diseases here in this category in the neglected space are many, so we are very targeted on what we support. And this is just to give you a little bit of granularity in terms of the interventions across the diseases. This information will be available to you so that you look at it in your quiet moments. Our activities are currently involving 37 African countries, and of these, we mainly have clinical trials in 31 African countries. As you can see, we have quite a big footprint across Africa. And where we do not have, that's where we have the capacity development activities as well to build the base for clinical trials. And of course, the type of trials here and the diseases covered matching the disease epidemiology in these countries. This is just a bit of a feel on investment in ethics and regulatory environment, strengthening the environment there so that we support high quality ethical studies, and also where we have investigational products requiring regulatory approval, that this can be facilitated. I mentioned an alumni platform that has been set up to network the fellows. I mentioned 119 under the current program, but we also had another 60 from the first program that are all networked. And when you're looking for fellows to collaborate with, this platform provides their portfolios and the areas they are working on. It's a good tool for you to know who is working where, because many of these are actually the research leaders that you may want to collaborate with in future. How is the UK performing in the program? As you can see, the United Kingdom is involved in a number of projects that we support. And actually in the EDSP program, I can say that almost all countries that we are working with, there is UK involvement. So UK is a key partner in the EDSP program. Coming in a little bit in terms of institutional involvement, you can see that the Liverpool School is doing fairly well. We currently have 12 projects that the school is involved in. And in terms of total funding within the UK, the Liverpool School is coming number 4. You see that the University of Oxford, which has fewer projects down because they're mainly involved in vaccine research, their budget is a little bit higher. And I'm believing that the school will even come even closer to number 1. Taking you now to the disease portfolios where we're working, starting off with HIV and associated infections. As you can see, we have clinical trials cutting across drugs, vaccines, and diagnostics, ranging from studies like the Caprisa, which is involving long-acting, slow-release preparations, which are implants being evaluated, the CHAPAS, which is evaluating optimization of antiretrovirals for children, Ambition, which is evaluating treatment for cryptococcal meningitis, the CHAP study optimizing treatment, pre-exposure prophylaxis for use in adolescents, the PROMISE study looking at the infant space, the breather study, which is also looking at innovative ways of treating and dealing with adolescents, where they have a weekend off and using the long-acting injectable antiretrovirals, and the use of antiretrovirals in pregnancy. Coming on to the vaccine space, we have the Mosaic vaccines, the PREVAC, which is a combination of vaccines and ARV and pre-exposure prophylaxis, and the use of neutralizing antibodies in the prevention of mother-to-child transmission, and a number of studies that are looking at also making sure that even the babies that usually left out that may be exposed to HIV can easily be diagnosed and also followed up, and the studies that are looking at improved diagnosis of cryptococcal meningitis. In the TB space, it's actually a broad portfolio as well, starting with consortia that is evaluating different anti-TB drugs at different stages of development. The VIRTUE study, for example, that is combining modeling and preparation of drugs for use in pregnancy and also in children. TREAT study that is looking at combined interventions for TB and HIV at the population level. Treatment simplification studies that are looking at development of drugs for both drug-sensitive and drug-resistant TB, and a broad range of other studies that are going on in the same space, again, trying to optimize and shorten the treatment. And coming on to the vaccine space, where we have different approaches. For example, the POR-TB, this is using another approach of not preventing infection, but actually looking at the prevention of relapse of TB following treatment. And then you have the other 2 studies that are looking at new alternatives to BCG. One is bioengineered, another one is attenuated. The PRIME study is in phase 3, and it's one of those big studies that is involving close to 10,000 babies. Diagnostic space, we have a number of diagnostics that are being evaluated at point of care, and also prognostic markers, prognostics that can be able to give indication that these are individuals, for example, that will respond to short treatment regimens so that not all the population is exposed to that. Going on to the malaria space, we have quite a bit of studies. We have the IMPROVE study that is looking at dihydroartemisinin piperacin in the prevention of malaria in pregnancy. The MAMA study, which is looking at the same drug but in the population that is exposed to infected with HIV. The triple antibiotics anti-malaria therapy. I have to say that this particular one, which is the triple anti-malaria therapy involving artesunate, amodiaquine, and atovaquone proguanil, there's going to be a change to that because of the severe side effects that have been identified that have to do with extrapyramidal side effects, where the amodiaquine element will be replaced with artemethyl-lumefantrine. And then we have the use of artesunate, the use of pyronaridine artesunate in pregnancy. We also have other second generation artemisinin combinations where you have the semi-synthetic ones and also in combination with drugs like ferroquine. We have the frontrunner TAF from Novartis, which is being evaluated, is now going to phase 3 in Burkina Faso, Gabon, and Mali. And then we have a portfolio of different levels of anti-malarials, different levels of development for both uncomplicated and complicated malaria in partnership with MMV. On the side of vaccines, we have the multi-stage vaccine development. This is in partnership with the University of Oxford, and the transmission blocking anti-malaria vaccines that we are developing also as a portfolio with PATH. Moving on to the NID space, a number of studies that are looking at leishmaniasis, reformulation for preschool going children for praziquantel, moxidectin, combination of ivermectin and other antihelminths. On the side of heart, some drugs that are being developed for leprosy, and also looking at some of the side effects that are associated with products in mass drug administration. For example, the heart fibrosis that is associated with some of these. So quite a number of studies going on in the neglected space. Vaccines on the side of NIDs are limited. We have one study that is looking at the post-Kalaza dermal leishmaniasis. That one is the vaccine in phase 2 testing. And a couple of diagnostics that are going on, for example, in the area of heart, and also cysticercosis. This is one of those studies that is quite interesting in an area that has been neglected for a while. Emerging and re-emerging infections, a couple of studies that are looking at Ebola, yellow fever, and also the PREVAC study, which is quite interesting. This is a study that is looking at all individuals that have been exposed to Ebola vaccines for an extended period of at least an addition of 2 years to see what happens to these individuals and looking at the immunological markers and anything that could be missed. And of course, we set up consortia for epidemic preparedness. We have targeted studies on the diarrhea and lower respiratory tract infections and vaccines for ETEC, the typhoid vaccine, which is a post-registration study. Excuse me. The oral vaccine for Shigella, and we also have the baby gel, which is actually one of the studies here, and this is really looking at the use of baby gel in prevention of neonatal sepsis. As I said, the school is involved in a number of studies, for example, in the efficient diagnosis of HIV and TB, preventing pregnant women from malaria, the IMPROVE study, optimizing treatment regimen for, this is the IMPACT study, that is really in the knowledge translation area, and again in the same on the side of pregnancy policies, and a number of studies in the HIV area and cryptococcal meningitis, TB, and empirical and the baby jail study that I mentioned. But I've talked about what is happening. Is the program really delivering tangible results that are making a real difference in the lives of people across sub-Saharan Africa on what has been done so far? We have studies that have been on preparation of fixed dose combinations, both first and second generation antiretrovirus. There are studies that have been quite successful with making products available, and this is a study that also supported the registration, FDA approval of one of the products, prevention of mother-to-child transmission, the Ebola study that contributed to the policy change in WHO. Glad to see Professor Jeffa here, who was involved in the REMSTAT study that provided evidence on cutting early HIV mortality due to cryptococcal meningitis with improved screening of individuals that is helping the managing of advanced HIV disease and rapid initiation of antiretroviral therapy. Recently, we had this relatively simple study on the use of prednisone in reducing the adverse events associated with TB-associated immune reconstitution inflammatory syndrome, which is actually reducing the risk by 30% with a fairly cheap drug. The regional networks of excellence, for example, the West African Network of Excellence, if you look at before 2000, the WHO was, you have a region in West Africa of 250 million people, where the drug-resistant data was based on only 3 countries. And following the data from the Regional Network of Excellence from 9 countries, the data was very different. Looking at, WHO had a figure of 20% drug resistance to any TB drug. And these studies show that it is 53% in West Africa. Multi-drug resistant TB, it was 6%, and the data shows 35%. These are the kind of data that are coming from the regional networks of excellence. Work that contributed to the knowledge on the use of GeneXpert assay for diagnosis of pulmonary and extrapulmonary TB in adults and children. Work that has resulted in supporting registration of Paramax and also registration of dihydroartemisinin piperacin is work that we have supported through our collaboration with MMV. The work that is looking at the impact study that is improving the impact of existing malaria product, especially being able to document this better, providing evidence to WHO in the evidence review group. On the side of praziquantel, which is widely used, no preparation available for preschool children. And this is a study that is now in phase 3 and is going to generate very useful data in this space. We've contributed quite a bit on preparedness for Ebola, and many of the countries that are actually responding better now is because of some of the work that we supported on preparedness. In the area of regulatory and ethics, supporting countries to set up clinical research regulation and ethics in a more transparent way so that partners can know what is going on. On the side of ethics, we recently had the development of the Global Code of Conduct for Research in resource-poor countries that was adopted in the European Parliament and is now available through the Commission. We have the mapping of clinical trials that is really facilitating the work in addition to clinicaltrials.gov through the Pan-African Clinical Trials Registry that currently has 1,500 clinical trials registered. A bit on funding opportunities. I know that you want to know what is available. Currently we have, as part of our 2019 calls, we have 5 calls that I think are relevant. on research and innovation activities. And as you can see, many of these have deadlines. I'm mainly referring to this category here. The first 4 have deadlines of November, December. The 5th one is one that we'll be doing on Lassa fever vaccine development. We'll be targeting late-stage development, but that one will be a joint call with the Coalition for Epidemic Preparedness, the CEPI coalition, but we are providing the large side of the funding towards that. The others are mainly fellowship schemes and also the coordination and support actions to support infrastructure development. What's the future perspective of EDCTP as a program? Well, as I said, we are in the 2nd program, and next year we'll be launching our last set of calls under the current program. That will be the 7th year of implementation of the 2nd program. But because we support activities that run for a minimum of 3 years, we need to allow for implementation of those activities so that they are finished by the end of 2024. But the expectation is that the next program, which will be associated with Horizon Europe, will start in 2021. And our thinking is that the focus will be maintained on unmet medical needs of vulnerable populations and infectious diseases, maintaining the scope on clinical development of medical interventions, but with a greater emphasis on phase 2 and 3 4 clinical trials plus product-focused implementation research. There is a increasing drive towards more patient-centered approaches that promote cross-disease, interdisciplinary, and explore opportunities offered by new technologies in the context of integrated patient care, paying special attention to the changes in the clinical regulations and the revolutionizing way of clinical trial processes in the member countries and also companies, not forgetting the vital gap of the interaction between infectious diseases and non-communicable diseases, and the issue of diseases of epidemic potential and the growing threat of antimicrobial resistance. With this, I've talked about a number of projects. We have these resources available on our website. You can go in and see what is available so that you know what is going on. And we're also releasing case studies on all our clinical trials so that you can have a snapshot of what is happening, which can also help you to generate new ideas. So with this, thank you very much for listening.
Thanks very much, Michael. I'm sure Michael will be happy to answer any questions you have, preferably about EDCTP rather than his time in Liverpool.
Yes.
Thank you. Thank you very much. Can I just pick up on one of the last comments you made about
Yes.
The interaction between non-communicable and communicable
Yes.
diseases? And does that signal an interest in going beyond those infectious disease, poverty-related infectious diseases, perhaps to looking at cardiovascular, respiratory, metabolic cancers separately, as well as the overlap between those non-communicable and communicable diseases? Because of course the non-communicable disease epidemic is well on its way, if not already there, and I feel it's maybe not being given the priority that's needed.
Yeah, thank you very much. As you noticed, I mentioned that there is an increasing growth of having a patient-centered approach and the interaction between diseases. It is recognized that the infectious diseases do not exist in isolation. Many of these patients that have infectious diseases, they either have co-infections or they have comorbidities. We have a limited budget. We cannot go full-blown into non-communicable diseases. But where there is that interaction, for example, when you talk about individuals that are on antiretroviral therapy and are developing problems that may be associated with diabetes or hypertension, these are areas that will be supported. When you're looking at individuals that may be exposed to Kaposi sarcoma, some of these are opportunistic infections that may be in the cancer space. Those are the areas that will be supported. Increasingly, diseases like sickle cell disease are getting prominence, and these are to be treated as comorbidities within these areas. So that's the kind of thing that I'm referring to.
Yeah, Michael, I find it very difficult to budget for a trial, and I find it difficult to work out how long a trial is going to last because of problems with recruitment and follow-up. They're very complex studies, the budgeting and the implementation of them. You've got over 100 trials here. How do you manage the complexities that arise from this with investigators running out of money or investigators recruiting slowly? What kind of mechanisms do you have? What flexibility do you have in EDCTP to deal with that kind of thing?
Thank you. That's a difficult question, and especially difficult when you're about to negotiate a contract with me. But yeah, so that was a joke. No, we have different approaches. Of course, we have some benchmarking that is done based on sample sizes, where there is some prediction on what is realistic, and also considering the stages, considering whether these are outpatient or inpatients. Usually the costing may be different, but we're also using two different approaches in funding clinical trials. We have trials that are funded on basis of projects, and we have trials that are funded on basis of portfolios, where we have, say, 3 or 4 clinical trials that are in one portfolio, and these are running for a period of 5 years, in which case we have a budget that has flexible activities in there. And this is where we have, for example, the multi-arm, multi-stage clinical trial designs, which are adaptive. And in that case, there might be ongoing changes with clear go, no-go criteria. So what we do in those situations is that we agree on the overall budget, but we also have an oversight committee that works closely with the group, so that where there are critical decisions to be made, realistic decisions will be made without in any way thwarting the efforts of the work going on in the field, but also letting us know early that there are changes in the way that things are budgeted. So there is that kind of flexibility, and we are trying to allow for more of this.
Thanks very much for your talk. It's really good to see that a lot of the work is already impacting policy, at least at global level. And I wanted to know, with the huge amount of work going on in a place like Africa, do you have a requirement that there be a strategy for engagement of policy, policy pathway engagement in the environments where the studies are being hosted? And if you don't have, is that something you want to consider going forward?
Okay, thank you for that. We have a multifaceted approach. First way of addressing this is that for studies, especially that are in late stage development, we usually require involvement of collaborators that are part of the disease control programs or involved in policy, so that it's not just information passed on to them, but they are already part of the process. 2, we also require a policy engagement strategy for these kind of studies. The third way of approach is what we are doing at the level of WHO. And with WHO, we are engaging WHO at the regional level and at the headquarters. At the regional level, there's work I've not talked about here. For example, we are supporting the strengthening of the national health research systems that is working with WHO to bridge that space between research results uptake in countries and the research environment. And at the regional level, at the headquarter level, we are engaging with, now WHO has restructured. They have a science division where they have a global health division, and the regional director, the Director General of WHO has recommended the head of this to be an observer on our scientific advisory committee. So we are actually even called in when policy meetings are happening, so that we have a top-down approach and a bottom-up approach in addressing policy issues. Thank you.
Thanks, Michael. My question is on the RIAs, which are I noticed the deadlines are for the early part of November.
Yes.
So for someone who is based in the UK and trying to put in for these applications, how
Yes.
does what are the prospects in terms of considerations, given that we may not be fully part of the EU coming end of the month?
Well, it's one of these situations where I'll have to say I do not know, because I don't know where things are going to go. But I really am encouraging a very pragmatic approach. We are encouraging applications to continue, but to avoid situations where applications are ineligible, in a sense that where you are required to have at least 2 European collaborating institutions. In this case, you want to make it 3. For projects that are funded and have existing contracts, we have an obligation to make sure that these are continue, and also talking with the representatives, representation from the UK, their efforts to make sure that these are underwritten, to make sure that even if it was to go the other way, the UK investigators are protected in this sense. And who knows, nothing may happen. So use a pragmatic approach. Yes.
Thanks, Michael. In your going forward with EDCTP,
Yes.
you have chosen to focus on phase 3 and phase 4 trials. What's the rationale behind moving from covering the whole scope of clinical trials to the later stage clinical trials?
No, just to make the correction, we are continuing with an end-to-end product development, covering phases 1 to 4 plus product-focused implementation research, with a slight shift to the right, having an emphasis on phase 3 and 4, and product-focused implementation research. In terms of investments, this is just looking ahead, looking at, we are increasingly getting feedback, especially from the countries where the work is happening, that a number of products are being developed, and these are developed in highly controlled, regulated environments. But little is done to evaluate these products in the real-life environment and making sure that the country contexts are taken into account. So we want to make sure that we pay attention to that space, given that we are putting quite a lot of investment in bringing the products forward. Secondly, we also want to engage another funding source that is often not optimally used, and that is the development cooperation investment, that have more interest in the late stage development and making the products accessible to the people that need them most. It's just a slight shift, but we are continuing with the end-to-end product development. And the discussions are still going on because it hasn't yet been finalized.
Hi.
Yes.
just related to that, and again going to the left of that pipeline, given that the advent of more and more human challenge models, is that something that EDCTP funds or would fund?
Yeah, actually, as I said, we are still signing a number of contracts. We have one that is, especially the portfolio one, that is having a number of human challenge models. So yes, that is part of it. You'll find that these are usually built in. Yes.
Sorry.
Yes.
The column almost at the end.
Yes.
Article 1. Does that envisage an academic being faced with a company developing products, designing trial,
Which?
Placements?
Oh, the one that is involving placement. What normally happens is we have researchers that leave their institution and they get an attachment for usually about 12 months, but they usually have a reintegration project that they work on. So after being attached to a company for 12 months and getting the specific skills that are required, then they go back to a home institution and they implement a project within their home environment, applying this expertise that they've acquired.
So that implementation is covered in the 6 months return?
In the 6 months return, yes.
Yes. Last question.
Thanks very much for your talk. I noticed that you mentioned collaborative mentorship fellowship and also career development fellowship. And my question is related. Do you have particular attention to the development of interdisciplinary researchers in terms of like from the very beginning nurture them and then career development, how to support them?
Okay. For the career development fellowships, it's really the nomenclature. In this case, it is referring to researchers, and these may be clinicians or postdocs within their first 5 years postdoctoral period, that they may be working with a mentor who is an established researcher, giving them some guidance, but they are doing their own work, developing their independence, and also beginning to develop a research team. So the funding is to support their salaries, to support some money to start something in terms of a small team and the research activity itself. So it is in that space. And the career development, in this case, it's meant to be the individual developing themselves with a bit of mentorship. Yes.
In your last slides, you also mentioned like promoting interdisciplinary research.
Yes.
So I'm just thinking like then, if there are any concrete policies or directions in this direction to support interdisciplinary research?
Well, when it comes to the fellowship schemes, we are not prescriptive. It can be in any discipline that is related to clinical research. It could be this person may be working in immunology, this person may be involved in parasitology, clinical pharmacology. They may be working with social scientists. So it can be interdisciplinary in a sense. Yes.
Definitely the last question.
Thank you. Great honor. So I had a question about the fourth call from the left, strategic actions on product-related implementation research.
Yes.
And it says on your website that this is one of the few calls where you need co-funding, and that's mentioned as should leverage major support from other funders. I wonder if you can translate that for us. And I also wanted to say I was delighted with your last slide, from your presentation, because on the left was Ken, our sonographer from Camry in Kenya.
Thank you very much. That shows that there is activity happening there. Yes. This one is a strategic call. And as you can see, it is product-focused implementation research. What is required here is we also want to leverage co-funding, and this is a 50% co-funding, cash and in kind, and this is where when you're doing a prospective project, for example, if this is a 10 million project, then you apply, but you come with a 5 million part, which may be cash and in kind. But for not retrospective, but prospective, yes.
Is this 50%?
Yes, it's 50%.
We're sure you have it, FICO. We just take this opportunity to thank Michael for an excellent presentation and give us a really good overview of where EDCTP is, what it's achieved and what it hopes to achieve. And Michael will be around for a little while after if anyone has questions they want to ask him face to face. Thank you.
Thank you very much.